Build it and they will come.
True that. Is that Rome?
No, it's Field of Dreams.
Oh.
Is that Rome?
Kevin Costner, baseball movie.
All right, welcome back, guys. Back to the OuchCast. I'm Neal, Rakesh, and I have another special guest with me here today. It's Dr. Anish Patel. He is the CMO of AIS and also the managing partner at National Spine and Pain. Did I say that right?
You did say that right. Thank you for having me.
I almost messed that up. I knew I said it, and I was like, I'm going to get it.
It was perfect. Thank you.
And it's interesting. You have a wealth of experience. You've been doing this for a while, and I think a lot of people that have seen you around kind of know your face because you've been doing this for a while, and that means that in some ways you're probably pretty successful if you've been here for a while.
I would like to think so, at least in my own mind. Yeah. I'm about 18 years into practice now, and the last 13 of those were at National Spine and Pain. Originally started off as a very small company with a few offices in Maryland, and with private equity infusion, we've now grown to about 180 offices across the United States.
180? That's
Correct.
ridiculous.
Yeah, 180 offices.
What'd you start at?
4.
How did you even find a place like you come out? Did you come out of like fellowship and this is the first job you get?
It is not. My first job out of fellowship, I actually opened up a private practice outside of Pennsylvania the year after I finished fellowship. And I was there for about 3.5 years. And that was the time when private equity had started coming into the scenario of infusing cash into pain management practices. And I was one of the early sellers just 3 years out of fellowship. So it was actually probably much more lucky timing than anything else, as opposed to actual intellectual prowess. I was in the right place at the right time, and I sold the practice in Pennsylvania. And then I took about 6 months off, and I was recruited by National Spine and Pain at that time, who was going through a relatively rapid expansion. They had 6 doctors and 4 offices in Maryland, and they were looking to really organically grow through that state.
And then you just ran with it.
We did, yeah. I mean, we had very good organic growth in the state, and then eventually this caught the eye of a mid-cap size private equity firm who was interested in purchasing us. And I'm sure, as you guys are well aware, that when that happens, an infusion of cash is usually influxed into your practice.
I love how you say that so like eloquently. An infusion of cash.
It is an infusion with the premise that you are going to further expand your web and your network, which is what we did. So we were given free reign. At that time, that equity firm was very pro physician leadership. So we were able to do our due diligence, and we just started acquiring adjacent state practices until where we are today.
I like that. So I think your experience is going to be very, very helpful here, because today we're talking about private practice and essentially becoming successful in private practice. And we have 2 special guests here today as well. We have Dr. John Akhnoukh, who is at Minimally Invasive Spine and Pain in New York. And we have Dr. Mark Jones, who is also another interventional pain physician at the Pain Medicine of the South in Knoxville, Tennessee, and one of my old co-fellows. And they're both kind of in the early phases of their private practice career. How you guys doing?
They're great. Thanks for having me. Really well. It's actually Empire Minimally Invasive.
Empire. I knew I was gonna miss that.
You almost made it.
I had one.
You almost made it.
Word.
I do like
one word.
I like how you added the Pain Medicine of the South.
Is it really? Is it the?
No, it's not.
It's not.
I like
the?
it. It might be now.
It should be.
It should be now.
Whatever. I should have switched one word. Whatever. I'm close. That was a lot of words. Let's start with something easy. What for you guys coming out? What made you choose private practice? What was the allure? And I already kind of know the answer from Mark, but
So I mean, I joined my dad's practice, so it was kind of no brainer for me. But I mean, more than that, I like the freedom and the authority that you have to kind of do what you want. In private practice, I really wanted from the early on. I really wanted to get into being involved with industry and doing a lot of research. And I just got my first RCT about a month ago, not even a year in.
Dope.
So,
congratulations.
Thank you. So I mean,
when was your first RCT? Is that that's pretty young?
29.
29?
Wow.
Okay. 29.
Beat me by 5 years. Okay.
Yeah.
All right, Anish.
Never mind. Okay.
So
What about you, John?
So for me, I always knew I wanted to go into the private sector just because, pain management's one of the few specialties left in medicine that still has that entrepreneurial feel to it. And there's so many avenues that you could take, essentially what we do, so many different interventions that we could provide. And sometimes that's not easy to really, push the limits in an academic institution where there's a little bit of structure and other specialties that don't really want you to expand on certain interventions. So I felt like in the private world, I was actually able to kind of push those limits and hopefully at some point continue to, expand, our field.
Yeah.
Am I hearing that a lot of the part was you didn't want to deal with the bureaucracy of academic institutionalized pain medicine?
Yeah, pretty much. You know what it is? It's just like other fields, interventional radiology, interventional cardiology, there's a lot of pushback. We don't have our footing yet in the door, and I know it's going to be a battle, unfortunately, but it's something that I definitely feel like I would want for my own family. So I want to be able to provide that out in the real world.
I might push back a little bit on that we don't have our footing yet. I mean, that's kind of what I was anticipating to deal with getting out, but I've really had a pretty dang warm reception in the Knoxville community by spine surgeons and pretty much all the medical community. It's been nice to see.
Do you think there's I don't mean to interrupt, do you think there's a bit of regionality in that decision process? Southern Knoxville, Tennessee, the greater New York, New Jersey area. It's always been an interesting concept to me about multiple specialties kind of delving into the same basket of procedures and patient population. And I have noticed from myself that when you tend to flow a little bit further to the south, it's much less homogenized and everybody kind of does their own thing and everyone's happy. But when you start getting up to the more metropolitan areas, you do start to see a lot of infighting. Would you agree with that?
I agree. And, one of the things I see is that it's not like a lot of our, other specialty counterparts are given pushback, but a lot of the academic institutions that I was exposed to, the major ones in New York City, it's really hard to get in some of the procedures that we're teaching here at WAPMU into those facilities. So, and I've worked with lots of great spine and orthopedic surgeons, neurosurgeons that are actually encouraging what we're doing, just not seeing that as much in the academic setting.
Anish, you said 180 practices, right? They gotta be
as of last week. I could honestly,
it's like 185.
I can't tell you what's happening.
It's like on this phone, it's like 185 right now. So obviously all in different regions.
The whole East Coast, from New York all the way down to Florida, just across the Gulf into Texas.
Is there something that you found that's worked? Like, have you seen a strategy that works for a practice to be able to integrate well into like that community where it's not like that infighting?
I will tell you, just from personal due diligence and being part of the M&A team for our practice, that the successful practices understand the community, and they usually have a long-standing history. So most of the groups that we've acquired were already very successful and running a top-notch facility. It was not one of those where we came into a clearinghouse and cleaned house and renovated an entire new practice from inside out. Most of these places are pretty successful. And what I've noticed is that the successful practices, like I said, they understand their regionality. For example, if you're in New York City or if you're in upstate New York, you're going to understand the demographics, the logistics of your community, the competing physicians, the competing specialties, et cetera, et cetera. And you've probably already figured out a way to maneuver through that landmine field so that you're going to be successful. In the South, it's much more open. I find the South to be some of our most successful practices. So if you look at National Spine and Pain, the successful practices start right at the Mason-Dixon line from Maryland down. Not saying that above New York and New Jersey and Connecticut aren't doing well, but it takes more work to keep those practices moving and successful as opposed to the practices as we start going down south. Obviously, state guidelines dictate a lot of how well a practice is going to do as far as economically and revenue management. But overall, I would tell you that the places that do well are the ones that understand their demographics and logistics.
So you're saying I'm going to want to crash at Mark's place first over John's?
Yeah, play well in the sandbox is what I've always said. If you play well in your sandbox in your community, the fighting that you hear about between neurosurgeons impeding or us impeding on radiologists and vice versa, it tends to go out the door with some clear lines of communication with your peers, I think.
And just out of curiosity, given that, I guess, the power that comes with having that many offices, does that bring anything to the negotiation table? You know, with the insurances?
Everything to the negotiation table. Obviously, a practice of our size, specifically in the DMV area, the District of Columbia, Maryland, and Virginia, our practice provides services to probably about 70% of the population of all those states combined.
Oh, wow.
So when we had to go back to the table to renegotiate contracts, most recently with Blue Cross, you have a lot of leverage in numbers. So if you're providing services to a large part of the population, you do have negotiating power at the table, right? It's going to be much harder for a single shop or a two-shop practice to say, hey, we want to reconstitute these agreements that we have from 4 years ago, and we would now like this, that, and the other. It's unlikely, because if you're not large enough to really provide services to a significant amount of the population, the carriers don't care. There's going to be 5 other practices that are going to be willing to take that fee going forward. But if you have a majority shareholder status as far as patient population, then they have to hear you.
Do you guys find that there's carrier issues when you're like
100%? I get pushed around all the time.
Like, what's the kind of things you run into?
Well, I was telling somebody earlier about all the pitfalls of private practice, especially when you're a small shop. Like one of the very first spinal cord stimulator implants I did last summer.
Yeah.
I just got paid for it. In my last 15 or so with one particular insurance company, like a commercial insurance, they haven't paid me my last 15. Every single one of them are under review.
That's crazy. Most people that are starting a practice probably can't like sustain themselves like that.
Yeah.
That's is that one specific provider, or is that like everything? You're noticing that's a mixed bag.
It doesn't seem to be a whole lot of rhyme or reason to what they choose to pay and the criteria that determines how they pay for it.
Is it a prior authorization issue, or are these being
no, it's not
authorized prior to the procedures?
It's authorized prior to me performing the surgery, and then afterwards.
Authorization doesn't mean payment, right?
Yeah, payment. Correct.
That's crazy.
That's the problem.
It's wild.
It's a tease.
Really wild.
Yeah.
It's a tease.
Yeah, that's absolutely right.
Oh my God. Do you find that same thing, John?
You know,
He's like, no, I never run into it. I don't have that problem.
So actually, you know, one of the things that one of my hobbies is actually coding and billing. So, you know, I developed.
That's a fun life you live, John.
Yeah, like
yeah, seriously.
I'm not staying at his house. Not staying at his house.
So we're very aggressive. The reality is with these insurance companies, you need to be pretty aggressive. One of the ways around, you know, being a small business, IPAs, independent physician associations, where you can essentially
the beer, obviously.
Yeah, exactly. Not the beer. But essentially what you could do is you can essentially go, you know, with a group that's represented of a bunch of other physicians in the area. And then you'll have a little more negotiation power with those insurances.
Is this like a GPO?
Yeah.
Okay.
And so
What was a
you
GPO
always
for
have
everyone?
Group purchasing organization.
Perfect.
Yeah.
Just for the people at home.
So, I mean, there are opportunities, but you have to kind of be a part of those groups. But, you know, the power of 180 offices is very different. Or obviously an academic institution having, you know, an entire hospital, they have a lot more negotiation power and obviously get a lot more reimbursement. You know, just going back to one of the things you were saying about, well, someone starting off, well, how do they start making money if they're waiting so long?
Yeah.
Not all insurance carriers are taking that long. I mean, there are, for instance, Medicare typically will pay you in approximately 30 days. You just want to be careful with Medicare billing. You want to make sure you're doing everything correctly because they pay up front and they're not going to look at it until one day you get audited, and you want to make sure that everything's actually done accurately, because if they start seeing things in your billing that are inaccurate, they will typically, you know, start looking back, and that's when you can run into some trouble.
Is there like a documentation thing that's associated with this? Do you feel that like maybe are there ways to almost like be airtight where this doesn't happen, or is this going to happen inevitably?
That's a great question.
I mean, well, you're talking about whether you're not going to get paid.
Yeah, like what can you do? What can you do to ensure that this doesn't happen? Are there things? Is it inevitable?
Here's the thing. So when you're at an academic institution,
Yeah.
you go in and you do your job as a physician, and that's it.
Yeah.
Right. See ya. And private practice, I'm the physician, I'm the administrator, I'm billing, the coding, doing everything myself. So there's so much to job, and you can't.
You did say you love the autonomy of private practice. You did say that in the beginning.
You asked for it.
You were like, but now I'm everything. Now I got to do it all.
It's just there's a lot more to. So like for instance, I'm depending on my office manager and other staff to make sure that everything's done correctly, and they don't have the medical knowledge that we do, so they don't understand exactly which M96.1 for they might submit just chronic pain rather than the correct code when they're getting either something pre-authorized or for billing afterwards.
How do you set up on that? How do you set up your private practice effectively? And what have you maybe seen that's been done to set it up where everything runs efficiently? Not just from a billing standpoint, but from just a functionality of the practice to make sure that it's successful.
So, I mean, from my experience, which is very limited, the reality is you want to be able to build a referral base. I think that's very important. You want to start to get to know people that can help with certain aspects of the office that maybe you can't carry out since you're essentially providing the clinical duties. So people that know how to deal with the insurance companies, that maybe know how to get authorizations, that can work with suppliers to get you the equipment that you need. Obviously, location is a huge part, and I'm sure you guys can all speak to that.
Yeah.
So there's a lot of components of it, and unless you have some experience in business or entrepreneurship, sometimes it's better to actually start off, in a setting where you could learn from a practice, learn some of the ins and outs, and then take the knowledge that you've built, the connections that you've built to help, start something of your own.
What have you found has been, and Anish, you too, what have you found has been like the most powerful marketing tool strategy?
Yeah.
Word of mouth, hands down. I mean, people spend...
Does that mean Instagram?
No, people spend a lot of money on marketing divisions or marketing costs, and obviously, I think the one thing that most physicians have a problem with is understanding that sales and marketing is a part of medicine today. If you're not doing it, you're going to be left in the dust. It has a dirty sort of feeling to it when a doctor thinks that they have to go and market and sell themselves. But I'll tell you from personal experience, good management of your patients spreads very rapidly through the community, specifically to the referring physicians. You have a referring physician that sends you 4 patients. They go back to him after you've done whatever you were going to do, and they're doing fantastic. He's going to send you 10 more referrals. Now, I'm not saying that you can't go with the old boots on the ground marketing reps going out or plastering billboards all over the highway like you see in Newark. But I'm saying there's a cost-effective ratio.
I saw 2 on my way.
Yeah, they're all over the place as soon as you step outside.
No, mine's not up there.
It's either that or personal injury. It's all you're seeing. That's all you're seeing in the Newark
Making
corridor.
commercials.
Yeah, it's unbelievable.
Like a Better Call Saul.
But I'll tell you, it is something based on the scale of your practice and based on the liquid money that you have in your practice that you're able to spend on it. It can be used very, very wisely. And sort of going back to the question before about what are you doing to optimize your practice in private practice? I've always learned that there are 3 main components to a successful practice. One is a finance division, and this applies to a one office practice or a conglomerate. There's a finance division, there's an operations division, and then there's the clinical division. Under those, you have subsets. Now, you are performing a majority of those duties on your own, but at least you're understanding the concept of finance, operations, and clinical are independent. And if you have these 3 running effectively, you're going to do fine. All the other parts, like materials management, will fall under operations. Office management will fall under operations. Revenue generation is going to fall under finance. So these are all really, really important concepts I think you have to understand. One of the things that fellowship programs lack across our country, I think, is just a basic introductory, what I would call Econ 101 to pain medicine. Not everybody needs to have a full-on business degree to understand the mechanics and the intricate details of financial practices. But I think it's important for at least the fellows coming out today to understand the world that they're in, because the world when I entered financially was much different than where it is today. And that's something that we really should start implementing more and more into fellowship programs, I think. And it's going to help the young physicians that are coming out like yourselves really hit the ground running and accelerate their practice quickly.
How do you make that enticing for a fellow? I mean, when you say like, let's go, you're in fellowship and you're in pain fellowship or whatever, and you say, all right, you need to go to Econ 101.
Right.
It doesn't really sound very sexy.
I'll tell you,
That's not what I'm looking for.
Actually,
it absolutely doesn't. But I'll tell you, the one question that I get asked more at WAPMO, at Aspen, whatever teaching venues I go to, is why did you decide to do an MBA and how has it helped you at all?
Yeah.
And I tell people that I didn't do an MBA because I thought it was going to specifically make me wealthier or more affluent. I just wanted to understand the underpinnings of my personal practice. Should anything happen, should I lose this person or that person, that I could quickly at least fill in. I don't even have a healthcare MBA. It's international finance. So I'm not sure how that helps me long term. But that's not the degree that I'm talking about. Like just very simple issues about understanding the finances of an office. Just simple things. Accounts receivable.
And I agree.
For example.
I think it's kind of sad because in the medical field, really to kind of venture into that, I know a lot of people that are getting MBAs and healthcare MBAs or outside MBAs. And it's just like this general sense of taboo to talk about finances in medicine in general.
That's exactly
As a
right.
medical student, as a resident, I literally just speaking about some numbers just in my anesthesia residency, it was like taboo. Like I would get labeled this guy that just is concerned about money. But no, we're putting all this time and effort in our training and coming out at God knows what age of our training to finally start our practices with no knowledge. And then you have these big hedge funds, these big companies that are essentially able to step in and essentially manage these things because they understand the finances. So all of our hard work, we're not even getting the most benefit out of it, at least financially. Obviously, we are in many other ways. But it's just unfortunate that it's taboo. I totally agree.
Yeah, I mean, I think it stems from the fact that like medicine is, in its very essence, an altruistic practice. It's meant to help people. The fact that you would want to pervert it with a financial incentive.
That's well said. Perverted. With a financial incentive. That's well said.
It would. All right. I don't even know what other word to use now.
Just to tack on, on the heels of that comment, the way I've always thought about the financial part of the financial discussion of medicine is, look, if I'm not generating revenue, I can't keep my doors open. I can't offer services.
Exactly.
I can't treat patients.
For other patients, exactly.
Very simple. Profit margins are profit margins. Obviously, it's an altruistic specialty, but we do have mouths to feed and things to do.
Yeah, of
but
course.
without adequate revenue, you can't offer these services and provide care to patients. And that is usually the counterpoint discussion I have when anybody approaches me about, well, you seem to stress the financial aspects of your practice quite a bit. And I go, of course I do, because it allows me to treat more patients.
Right. It's also probably how you use that money,
Right.
how you
course.
reinvest that money
course.
to make your practice better, to make it more efficient.
Absolutely.
It's not like you can obviously make money and just pay yourself
Right.
or reinvest it to do better
Exactly
things.
right. Exactly right.
Anish, how have you found that the Medicare guidelines, CMS guidelines, have impacted your practice over the years?
That is a brilliant question. And I will tell you, over the past 8 months has probably been the largest impact with the LCD coverage changes that we've seen with Medicare, with the facets moving forward, et cetera, et cetera. And I'll tell you right now, it's looking bleaker and bleaker moving forward, because it's just a matter of time until epidurals follow that pathway, until radiofrequency follows that pathway, until our bread and butter injections start to follow the pathway. In our practice alone, we've had revenue changes of about 28% reduction in the last fiscal year, which is huge.
Does that
is
result in a lot of
massive-
practices closing down?
I would imagine that some practices are going to close down, but the smart practices that these two guys are running are understanding that you have to roll with the punches, and if you don't foresee the changes coming ahead of time and pivot yourself appropriately, you're going to be in trouble. But there are ways to offset this. There's two ways to maintain finances. You're cutting costs, you're increasing revenue. Increasing revenue is a little bit tougher right now.
Yeah.
Cutting costs, nobody wants to do. You don't want to lay off people, this, that, and the other, but you can be more cost effective in your practice. At the same time, you guys are coming out and starting young in the prime of what I call the technological breakthrough in interventional spine medicine. When I finished fellowship, the thought of one of us doing an interspinous fixator, sacroiliac fusion, or even handling a scalpel was preposterous, right? And now, every Tom, Dick, and Harry is performing SI fusions. Everybody's doing interspinous fixation. Everybody's doing peripheral nerve stimulation. These are not things that we had back in the day. But I would like to think that these are our answer to two problems. One is providing optimal patient care. All the studies that you're going to read about interspinous fixation done through percutaneous procedures are without a doubt showing that the results are the same, if not better than historical fusions. So one, treatment for the patients is really being optimized. And number two, you're starting to close that gap on the losses that you're getting from losing your bread and butter. So the revenue generation that you're making on these, what I call high acuity procedures, can offset the losses that you're going to be having, which you're all going to experience. Undoubtedly, every practice that's private that does pain medicine is going to be hit by the determination changes that we've seen, specifically with Medicare, like you asked. So if you are not seeing things a little bit ahead of the curve, if your team does not have the insight to look ahead at what's coming down the road, you're going to get railroaded when you try to catch up later.
For these high acuity procedures, are private practices that don't do these going to be susceptible to not being able to keep up with the rest of the market?
I think that the competition is so significant in the private sector right now. And the young physicians are being trained so well when they come out of fellowship that if you're not doing it, you're going to lose that patient volume to the guy down the street who is.
100%. I've seen it so many times. And they're like, why hasn't my pain doctor done some of these things? Or why doesn't he offer these things? And honestly, with the marketing, even from the actual procedures that's going on, I mean, people are coming to the office and asking about specific procedures. And I think that's also a part of the fact that the population is starting to become more educated. They know that they have options. They're not just blindly trusting, but they're looking into things. And a lot of the discussions I have with any injection or procedure I'm doing, I'm saying, go home, don't make a decision on the spot. This is just a consultation. Go home, research it, come back with some questions. That's the best thing you could do as a patient.
Don't research it too much, because your uncle's dog's aunt's friend was paralyzed from a trigger point. So.
Well, that's why you got to come back with questions.
Yeah.
So. We were talking about all the high acuity procedures and everything and how interventional pain has changed. What are you guys excited about right now?
There's a lot. I mean, honestly, the field that I'm most excited about is endoscopy. I'm really looking to kind of expand on the procedures that we already have and on future procedures using endoscope. I think one of the best things about our specialty is that we're allowed to, or we're able to do things through minimally invasive techniques because we have the fluoroscope, right? And as of the last, couple of decades, we're really perfecting our skills with the ultrasound. So I think the next step really is the endoscope.
I was really hoping you would say that. I was like, he's like, we're perfecting the technique with the fluoroscope. I was like, but what about the ultrasound? Like, what? Like, just a little bit.
So I think the endoscope is the next step, honestly. And technology is coming out, finer and finer tools. Images are phenomenal, and it just makes it more efficient, more safe.
You can plug a transducer into your iPhone now, right?
That's what. But how do you?
The butterfly.
How have you seen that? Because you must have. At one point, I think it's more profitable for fluoroscopy. But now we have these high acuity procedures with ultrasound.
Right.
That's got to be a big shift because the ultrasound is now you can do it anywhere, any clinic. You can do it in like a closet.
Yeah, I would love to tell you, but I'm going to age myself with this comment that ultrasound training in my day and age was nothing, especially an anesthesia-based program. It was nothing. So any ultrasound which I do, which I assure you my skill set's far inferior to you guys when it comes to ultrasound, is for the sheer fact that it was not part of my training. And anything that I honestly learned at WAPMU or ultrasound courses back in the day. But it's a great question because it is creeping in. I think ultrasound is more readily available to pain providers. Not everybody has the free liquid cash flow to go and rent a fluoro from the first day of their practice. And that can be multifactorial and impactful to their practice, I think. But overall, it is the wave of the future, like you've said. And I know you're a strong proponent of teaching ultrasound, and rightfully so, because it's going to lower the costs of healthcare. And at the end of the day, if we can lower the cost of healthcare in any way, we're moving in a positive direction as far as providing services to all of our patients, and at the same time, not really, really deeply impacting the pockets of the physicians. But when you asked about interesting things, I think there are two that are specific to me. One is sort of the resurgence of older things like the intrathecal pump. The intrathecal pump is something that's been around forever. And now we are seeing it slide so much more proximal in the algorithm of therapy for patients. In my day, in my fellowship, salvage therapy. Had everything done, had surgery. You've now placed the moniker failed back syndrome on him, pump. Now you're seeing it implemented very early on, even when somebody's on marginal or minimal doses of opioids. Opioid crisis has forced us in that direction, and I think it opens often care. The other one is, I think, the inner spinous fixation devices and actually manipulating the anatomy of the spine to correct and provide corrective solutions as opposed to spraying steroids on nerves. And I think that's interesting because we are now really blurring the lines and bridging the gap, to the chagrin of our neurosurgeon colleagues, between interventional pain medicine and surgery. So these are surgical procedures that you're performing, even though they're percutaneous. Don't be fooled.
Yeah.
You're utilizing surgical codes when you do these procedures. You're making incisions. You have to be prepared to deal with the consequences of complications. So those are the two exciting things, I think, to me, moving forward, along with the pantheon of procedures that we see moving forward, and the implementation of ultrasound.
I like how we started off with playing nice with other people in the sandbox,
Right.
and we just talked about doing other procedures that are surgical now.
Correct.
And that's got to be an interesting conversation when you're having that with your surgical colleagues. But I'm sure there's ways in which you've seen that works synergistically.
It can. Again, alma mater should be play nice in the sandbox. Do not try to confront your surgical colleagues. Do not try to outgun them. 9 times out of 10, they're in the administrative chain of the hospital where you're trying to get facilities approval. And you have to learn to work with them, not against them. And you can come to common ground. I mean, for example, in my community, my neurosurgeon loves doing implants. I don't do implants. I do stim trials. I do pump trials. When it's time to implant them, I send them to my neurosurgical colleague, makes him a happy man. The referral chain continues. He doesn't have an issue with me doing interspinous fixation on the appropriate patients. And it's I hate to use the word quid pro quo, but that's what it is as far as finances are concerned. But he understands and I understand where the line is, and we both understand that we have practices to run and families to feed. And the days of the interventional pain doc just being steamrolled by surgeons is gone, right? We have such large societies that do so much to promote our specialty and to make us a stronger union in general, that I would love to be challenged by the fact that the interventional pain community is probably becoming one of the strongest as far as political and administrative support when you compare it with others. I mean, look at how many meetings we have.
Yeah.
Right? How many societies do we have now?
Yeah.
Can't keep up, actually.
Sorry, I just broke
Too
my
many, matter of fact, probably.
But I agree, and honestly, a big part of it is also just deciphering which patients meet which criteria. So, I always say when I'm teaching the discectomies, there are certain criteria. You want this to be a successful procedure. At the same time, there are certain patients that require more invasive surgical interventions that are not, a part of our playbook at this point.
Yeah.
And I think understanding that and discussing that with your colleagues. What we're trying to do is not necessarily take away surgical interventions from these, counterparts, but it's more so to add more options in the algorithm. The less invasive, the quicker we're getting these patients back to work, back to their normal functionality is really the goal behind all of this. It's not necessarily a financial purpose. I mean, that's great too. No one's ever going to say no to that. But the reality is we want to give them the opportunity to have a quick fix that's going to essentially return their functionality.
Yeah. What about you, Mark? You going to build your practice around ultrasound now?
I actually just bought an ultrasound.
Portable?
Wait, did you ask me which one to buy? I can't remember.
Did.
Yeah, you did ask me. You're like, too expensive.
My dad has a degenerate ultrasound. I was like, I hate ultrasound. We don't need an ultrasound. I'm like, I trained with Akhnoukh.
That's half my training.
Right.
So, and it does offer, for me personally, with the ultrasound at least, it's just the quicker procedures that if the OR suite is being used with the fluoroscopy by someone else, I can go and I can do a couple injections or other things with the ultrasound.
And I think the key thing is there are procedures that are particularly more amenable and they're more efficacious with ultrasound. And we talked about this in the beginning. It was if your patients like you and you do well, you have good outcomes, it's that word of mouth.
Absolutely.
That's what builds your practice.
Build it and they will come.
True that. Is that Rome?
No, it's the Field of Dreams.
Oh.
Is that Rome?
Kevin Costner, baseball movie.
Oh God, that was terrible. Let's do final thoughts. Success in private practice. Anything you think we missed so far? This is obviously just we just touched the surface, but anything else you guys think worthwhile?
When you were asking earlier about like what do you think is like drives a successful practice, and you're saying outcomes and word of mouth, I think just a little more myopically, just in your own facility, I think that your staff and your practice follows your lead, right? And if you're driven, invested, and really pushing the envelope, then everyone's going to fall in line, and that's going to create your platform and your empire, and really enhance your ability to practice good medicine.
That's a very fantastic point. Very mature comment. You're dead on that. If the whole team works as a union, it's going to be fine. If there's any defectors in a practice, it takes one sour person to go viral and make the entire practice inefficient. So positivity is huge, and that's a great comment.
Yeah, John, what about you? Any last comments?
Honestly, from my own experience, it's really just patient experience that's driven. I was a part of a previous practice, and then I went out and started my own, and just the experience and the exposure that I had with patients, sitting down with them, being the one to see them post-operatively, to call them on the day after they do an injection or procedure. All of these things are personable, and they show that you care. And just like you guys said, those patients, whether they went back to their referral sources and told them or not, they told family, they told friends. They're the ones that tracked me down, because I'm not allowed to solicit after I leave. And they're the ones that literally made an honest effort to find me. And that's what helped my practice just start on a really good footing.
Nice. I appreciate it, guys. I think this was a pretty productive conversation, trying to figure stuff out for the private practice people out there that are listening. Thanks for stopping by.
Thank you for having us.
Yeah.